All right. Hello, everyone. Greetings from Turkey, Izmir. And we have two distinguished speakers today. The first one is Dr. Muhammad Yusuf Karim, um, who is division chief of hematopathology and senior attending physician in immunology at Sidra Medicine, Qatar. I want to mention his bio. He attended Trinity Hall, University of Cambridge, qualifying in 1993 with distinctions in medicine and pathology. He undertook medical rotations, completing the membership of the Royal College of Physicians and obtaining a registrar post in nephrology and general medicine. In 1998, he completed a master's in immunology at King's College. He was also a clinical lecturer and honorary specialist registrar in immunology at King's College from 1998 to 2004. During this time, he had the opportunity to continue working on lupus under Professor Graham Hughes, who first reported the antiphospholipid syndrome. In 2004, he was appointed as a consultant immunologist at Frimley Park Hospital, then at Guy's and St. Thomas, becoming clinical lead in immunology at the later. And he has been working at Citra for the last 5 years. He is a Sidra is a tertiary pediatric and maternity hospital in Doha, and he is the division chief of hematopathology and senior attending physician in immunology. So, Dr. Karim, you are going to present your talk, primary immune deficiency disorders, much more than recurrent infection. So the stage is yours.
Thank you so much. Thank you. Thank you so much for the kind introduction and for the kind invitation to speak from Professor Funda and Professor Ozer. Thank you. I hope you can see, hang on, my slides, 1 second. You can see my slides now?
Yeah, that's true.
Okay, perfect. So it's a pleasure to be able to speak at this the second webinar.
We are seeing not the full screen. Just we see. You see both next slide and the current one.
Okay, let me try again. And now?
Yes, that's great. That's great. Right okay, now it's
perfect. So it's my pleasure to speak at the second webinar of this year from Dokuz Eylül University and Sidra Medicine collaboration. And as mentioned, I'm going to talk about primary immunodeficiency, much more than recurrent infection. And in this talk, my learning objectives will be to summarize the advances in immunodeficiency, to outline the concept of immunodysregulation disorders, and then to illustrate the practical benefit to our patients and their families. So clinical immunology has a bit of a bad reputation. Unfortunately, the abbreviations and acronyms keep increasing and increasing. There's so many different CD numbers that it gets very confusing. And the increase is because there are advances in basic immunology. We've identified many new novel immune disorders. We understand a bit more about the pathogenesis of immune disorders. And there's very much a desire in the international community to better categorize immune disorders so that when different physicians in different countries are talking about disorders, they know they're talking about the same disorders. There's been a paradigm shift in the last 10 or so years. We used to talk about primary immunodeficiency, secondary immunodeficiency, primary antibody deficiency. And there was a recognition that actually primary immunodeficiency could be better described by inborn error of immunity. And this is because we know now that it's not just an impairment in the response to infection, but these patients often have other features like autoimmunity, or lymphocytic infiltration, and sometimes even lymphoma or other malignancies. So it's much more than just an impairment in terms of responding to infection. And indeed, the boundary between primary immunodeficiency and secondary immunodeficiency is becoming blurred. So an example of this is a patient with an autoimmune disease such as SLE, treated with a drug such as rituximab, becomes antibody deficient. In the most cases, this is because it's secondary immunodeficiency. But particularly in pediatrics, sometimes the drug is revealing an underlying immune deficiency. And we have seen this here. And there's been studies from other centers, including from Europe, where children who presented with either autoimmune hemolytic anemia and were treated with immunosuppression, it was later revealed that instead of a secondary immunodeficiency, they actually had an underlying primary or inborn error of immunity. And I said there was a vast increase in the recognition of these disorders, and it is true. In the last 10 or so years, there's been an increase from 191 diagnosed conditions to almost 500. And this is according to the IUIS classification, which is kind of the gold standard internationally. And the IUS classification has also now included this concept of immune dysregulation, about which I'll tell you a little bit more. So this is data on the left from the UK. Between 2012 and 2017, you can see almost a 10-fold increase in immune disorders, from 540 to just under 5,000. And I can tell you the level now is much higher. And on the right, this is international data from the Global Jeffrey Modell Centers Network. And it's dividing according to different types of immune deficiency or inborn errors. And you can see all of them are increasing. Particularly, you can see here, this is predominantly antibody deficiencies, which are the most common type of IEI. But all of the different lines are tending to go up. So there is advancement in clinical immunology. And how has this been achieved? So if I talk a bit about the laboratory first and then talk about the clinical. In the laboratory, we're achieving it through a range of programs. For example, newborn screening is available in a number of locations, particularly in the United States. So early detection. Then we have improvement in genetic and molecular techniques. So we now have clinical gene panels, whole exome sequencing, whole genome sequencing. And the cost of this testing is much, much less. And previously, say 10 years ago, it might cost, £2,000 for a whole genome sequence. We're now talking about the order of maybe £300, £400. So there's a major reduction in the cost of testing. There's also improvement in data analysis with bioinformatics and data storage for these very, very, very large files. And so genetic variants are often picked up. I'm sure any of you who've ordered gene panels or whole genome sequencing, you often end up with what it's called variants of unknown significance. And so the IUS have strict criteria for establishing whether a variant that's been reported is clinically significant. So just going through this, the first is that the candidate genotype is monogenic and should not happen in individuals who don't have the clinical phenotype. The second is that the particular genetic variant impairs, destroys, or alters the expression or function of the gene product. And the third is that the causal relationship between the genotype and the phenotype is also reproducible in an animal model, whether it be a knockdown or a reconstitution with the wild-type gene, showing that this has a recognized animal phenotype. And this is important because we need to prove when we find a genetic variant, if it's not known already, that this is indeed relevant to this patient's presentation. Now, does this molecular diagnosis, does this really help? How does it help? Well, it really does help the patient and family, not in all cases, but there are a number of ways it can help. It gives the patient and their family, particularly in pediatrics, a more accurate clinical diagnosis. This allows us to give more specific advice to the family regarding prognosis and has implications for therapies. So for certain inborn errors, there are tailored therapies that can be given. For example, for CTLA-4 or LRBA deficiency, we can use abatacept, which is CTLA-4 immunoglobulin. In some immunoglobulin errors, there isn't a specific therapy, but we know it's important to intervene early with stem cell transplantation. So establishing the diagnosis enables us to advise the patient and the family who is most suitable for early stem cell transplantation. And then we can give advice to the family for the future family planning, and for pre-implantation diagnosis. And siblings, of course, there may be siblings, and we can test them to see, are they at risk of having the same genetic diagnosis? The other way I mentioned is that clinical advances are taking place, and these are really important, just as valuable as the genetic advances. So partly this is because simply clinical care is better. So for example, the outcomes of bone marrow transplantation are better now than they were 10 years ago, because it's simply because of advances in medical care. The other aspect is the collaborative spirit. So we're having multi-center, both national and international collaborations. And when you're dealing with some of these immunodeficiencies, which are very, very rare, a single center may only have 1 or 2 patients with this diagnosis. And so if we have a multi-center collaboration, we increase the number, and then we can start making conclusions regarding the typical clinical and immunological features, the variety of variants that could be responsible, how these patients respond to therapy, and what is the likely prognosis. And then we can extrapolate from this to advise our patients at our own centers. And so these collaborations are occurring all over the world. And I'll talk a little bit about one that happened in the UK, and then I'll talk about one that's happening in the Middle East and North African area. So this is a study from the UK where there was a multi-center whole genome sequencing study where we recruited over 1,300 sporadic PID patients. And in this cohort, a range of different molecular defects were identified. Some of them are known genes, for example, NF-kappa beta-1 and TACI, but there were also new genes that were not previously recognized as causing PID. For example, the IBN S1ABP, which is an influenza virus NS1A binding protein. This was newly discovered in this study. Unfortunately, despite both clinical gene panels and whole genome, often in PID patients, the search for molecular diagnosis is not successful. And that's because of the complexity of the disorder. So still, at this stage, we're still unraveling these disorders. And if I show you some data from this study, if we look at the panel A here on the top left, essentially adult is the pink and purple, childhood is the green. And what you're seeing, the darker colors are the familial. And you'll see this being a Western cohort. The familial is much, much less than the sporadic. So both in adults and children. And if you look at the range, we've got common variable immunodeficiency, we've got combined immunodeficiency, antibody deficiency, autoimmune phenotypes, neutrophil and phagocyte disorders, autoinflammatory and SCID. Throughout, what we're seeing is essentially the sporadic ones are much more common than the familial. And you'll see the difference when I show you the data from this region. When we look at the diagnostic PID genes that were reported, what we can see, green is for previously reported, and the orange is the novel. And so you can see a large number of novel variants were reported in the study. And in the yellow, you can see the genes where they're highlighted in yellow. These were ones where the clinical phenotype was different from published descriptions of this gene being affected. And this shows you that variants in the same gene can cause different clinical phenotypes. So this data is from, as I said, from the UK. Just before I show you the Middle Eastern data, I want to try again, I said at the start, this is a talk about how immunodeficiency is much more than recurrent infection. Now, there are warning signs of PID which are used internationally, and typically these are to do with infection. And if you look at the 10 warning signs, nearly all of them are infection related, apart from failure to thrive, number 5, and a family history of primary immunodeficiency. But the rest are all to do with infection, recurrent or severe, or failure to respond to treatment. However, about 10 years ago, there was a review and an editorial from the chair of the European group talking about 10 warning signs. Do we need to change these? Are these still relevant now? And I'll show you a study from 2019 from the US. They looked at both adult and pediatric patients, and they assessed whether the relevance of these warning signs in these two cohorts. And what they found was actually the addition of autoimmunity in the pediatric PID cohort improved the diagnostic accuracy of these warning signs. So again, already starting to suggest that not just recurrent infection, but other features could be important. And this is a study actually from Turkey, and they assessed the 10 warning signs in both primary and secondary immunodeficient patients. And they found, as well as the warning signs, the standard warning signs, they found that parental consanguinity, chronic diarrhea, and a family history of tuberculosis were important warning signs for early PID diagnosis. And you'll see this theme, the parental consanguinity and the chronic diarrhea, come up again. So why could autoimmunity be relevant to these patients? Well, it's because of immune dysregulation. So in these inborn errors of immunity, we've got immune dysregulation. Now that could present as patients having recurrent infection, but it also could present as loss of inflammatory control, which could result in loss of tolerance and hence autoimmunity. And so these two different terms have been coined. One is primary immune dysregulatory disorder, or PIRD, and monogenic immune dysregulation diseases. Essentially, they overlap and are very similar. And you can imagine there's a spectrum. We have a spectrum going from here on the left, pure immunodeficiency, such as severe combined immunodeficiency, all the way to the other end, immune dysregulation, for example, ALPS, with presentation with autoimmune cytopenias, hepatosplenomegaly, lymphoproliferation, and sometimes lymphoma. These patients can have immune deficiency and can become hypogammaglobulinemic. And you can see in the middle, CVID, there are some patients who have common variable immunodeficiency who have simply recurrent infection, and another group who have a range of inflammatory complications. And so this side will have predominantly infections, whereas this side are getting a range of autoimmunity, lymphoproliferation, and we said enteropathy and IBD could present with diarrhea, and then even allergic phenotypes can be implicated, for example, in IPEX. So this is a report from late 2020, and what you can see, they talk about 430 inborn errors of immunity. Remember the slide I showed you from 2022 had 485. So 55 new disorders reported in 2 years. But the important thing about this slide is it's dividing these recognized IEIs into infection predominant, of which they say there's just about 300, and then 129. So just under a third of the whole group, which they would consider more immune dysregulation. And these are more immune-mediated pathology. And the therapy may be different. So, for example, in the infection prevention, you may be trying to replace what's missing with a variety of techniques. Whereas here, we may be talking more about immune modulation to deal with immune dysregulation. So I said I'd talk about data from the Middle East and North Africa. And this is the MENA group, which has collaborated, produced some excellent publications, guidelines on IEI diagnosis and management. And as you know, there are a number of Turkish centers in this collaborative group. And they recently published actually on immunodysregulation. So this was the recent publication from the MENA registry on MIDDs. And they found that First of all, the prevalence of MIDDs is higher due to consanguinity. They reported what the most prevalent genetic defects were, which were LRBA, particularly, and then LIST and RAB27A. The latter two, of course, cause HLH. And in terms of the presentation, infections were important, but also autoimmunity, organomegaly were also important. And I'll show you some of the symptoms here. So if we look, we can see respiratory tract infection here, almost 24%. We can see non-respiratory infections, about 8%. So infections there are accounting for about 32%. But we've got a whole range of other presenting symptoms, including autoimmunity, 18%, diarrhea, which again came up in the previous Turkey study, which I showed you, organomegaly, 13%, hair skin color change, which may be relevant to the HLH, the hereditary HLH patients, and a little bit of allergy here, 3%. So we can see that infections are important, but in this group of PIDs, which are more immunodysregulatory, other features are also important as presentation. If we look in this collaborative study at the range of defects, we can see LRBA, as I said, was most common. And then we've got LIST and RAB27, which are the HLH. We've got FOXP3, which, of course, is a T regulatory defect. And so we can divide either by gene type, or we can divide according to the syndrome. For example, is it HLH? Is it familial HLH? Is it a syndrome with autoimmunity and a Treg defect? So, for example, the purple here, which is this category, is you can consider LRBA, you've got CTLA4, you've got FOXP3 here, HLH with hyperpigmentation you have here. So you can divide it according to this, and this gives us a way of assigning different genetic diagnoses and also different syndromes. The other issue that's very important in this cohort, again, this is on the pie chart here. You can see the vast majority of diagnoses, the nature of the inheritance is autosomal recessive. And again, this fits back to the higher incidence of consanguinity in the region. I said at the beginning, it's important, again, to establish a diagnosis so we can advise parents and patients about their prognosis. And again, by dividing into these syndromes, you can see very big differences in survival. So, for example, in yellow at the top, we've got syndromes with autoimmunity and normal double negative T cells and Treg cells. Survival is pretty good. Here you can see this gray line is EBV susceptibility with HLH, and survival is poor. So by subdividing either according to the genetic variant or according to the syndrome, you can start to develop prognostic information, which is useful to patients and also useful to try and think about when you intervene, for example, when you decide to refer for stem cell transplantation. And again, this sort of data is only possible by collaborative efforts. If we only have single center, the numbers of patients would not be enough to come up with statistically significant data. So once we've established the diagnosis, then this has implications for treatment. And this is from a recent report about the future of therapy. So, for example, we do have medical therapies that we can use. For example, the JAK inhibitors, which we borrow from rheumatology, can be used for STAT1 and STAT3 gain of function variants. The PI3 kinase delta inhibitors, which are in research studies, can be used for APDS1 and APDS2. The best known actually is abatacept, which I mentioned earlier for CTLA4 and LRBA deficiencies. And my colleague here, Dr. Bernice Lowe, has been collaborating with a range of groups, including in Turkey, on LRBA deficiency. This drug works well to treat, for example, some of the inflammatory complications, such as inflammatory lung disease, with good outcomes. In some patients, however, there are no targeted therapies that we can give, and so we end up considering stem cell transplantation. There are a number of conditions such as SCID, some severe CGD patients where stem cell transplantation is curative. In some conditions, for example, STAT1, STAT3 gain of function, it's partially curative. In other conditions, such as predominantly antibody deficiencies, we tend not to transplant patients. And so again, this shows similar, but it's dividing it according to a spectrum. So if we're at this end of the spectrum where we're talking about antibody deficiencies and complement deficiencies, we tend to use medical therapy. We're talking about immunoglobulin replacement, antimicrobial prophylaxis. If there are inflammatory complications, biologic therapies such as B-cell therapies. At this end, at the extreme right side, we've got SCID, we've got Wiskott-Aldrich, we've got X-linked lymphoproliferative syndromes. These are conditions which are predominantly treated with usually stem cell therapy, stem cell transplantation, or gene therapy. And in the middle, we have conditions for which there are medical treatments, for example, abatacept, other small molecules. But then once the patients get more severe, you might be thinking towards stem cell transplantation. So it's not either or, there's a gradient of therapies. And thankfully, compared to 10 or 15 years ago, we have a lot more therapies than we previously did. And the therapies now can be much more targeted because of the molecular diagnosis and because of the collaborative efforts to try and use these treatments in a bigger group of patients. So just to summarize, I've tried to show you today that primary immunodeficiency, or the now new name, inborn errors of immunity, we don't any longer consider them as simply predisposition to infection. We can see from the data that these conditions can present or be complicated by a range of autoimmune, allergic, and lymphoproliferative features. We can see that the improved classification of these disorders is supported by advances in genetic diagnosis, multi-center clinical collaborations, advances in clinical care, and really it's enabled immunology to enter a golden age. And we know now there are early examples of translation of these new therapies into patient care, and the benefits of genetic diagnosis and targeted therapies are really starting to produce. So thank you very much for listening.
Thank you very much, Yusuf, for excellent presentations. We are going to have our questions and comments at the end of the presentations. I would like to ask participants to write comments and questions at the chat box. The next speaker is Professor Erbil Ünsal, who is currently Division Chief of Pediatric Rheumatology at Dokuz University School of Medicine, Department of Pediatrics. He has graduated from Ege University Medical School in 1988. Then he finished his residence training in pediatrics at Dokuz University Department of Pediatrics. He had an experience as a visiting clinician at University of Birmingham Department of Rheumatology and Diane Princess of Wales Children's Hospital, where he worked with Dr. Tautun Southwood and Dr. Clive Reader, and he became associate professor and full professor in 2009. He founded Department of Rheumatology at Dokuz University. He had a presidency. He was president of Turkish Pediatric Rheumatology Society, and he worked in establishment of the board curriculum in pediatric rheumatology, and also he's a member of Press and Printo. He published many papers and also international books, and he has a citation over 2000 right now. So, Professor Erbil, the stage is yours. You are going to present your talk about familial Mediterranean fever, revisiting a historical disease. Stage is yours.
Thank you, Erdar. First of all, I'm very happy to be invited to this lecture series, and I want to thank Dr. Karim as well for his excellent presentation. He talked us about immune deficiencies. Now I will like to talk about an immune aberration, which is common in certain regions of Turkey and Mediterranean, familial Mediterranean fever. So when we have children in pediatric rheumatology, in pediatrics with recurrent fevers, first we wonder if we have an immune deficient patient. But after making an extreme search in this area and trying to exclude immune deficiencies, we should be aware of FMF, which has a prevalence of a frequency of 1/1,000 patients. I mean, 1/1,000 people. I mean, each 1/5 of us are carriers. It's such an interesting disease that even in carrier state, if we have clues about signs and symptoms, I'll talk to you about later, we can make it as a disease, we can diagnose it as a disease and start treatment. My lecture plan is trying to go briefly from the history, inheritance pattern, clinical science, and importance of amyloidosis, and the criteria, Turkish criteria, and pathogenesis, role of innate immunity and pyrene inflammasome, an advantage of ancient pyrene mutations in plaque pandemic, and the treatment, and a project that we have working on. It's an ancient periodic disease, which is autosomal recessive in character, and it's a disease of brotherhood, I can say, actually. Most prevalent in Turks, Sephardic Jews, Armenians, and Arabs, and a Mediterranean-born disease. When it's called Mediterranean, Europeans and Americans call East Mediterranean, because in fact we cannot see the disease in Greek, Bulgaria, or Italy as well, especially as I told you before, with Arabs, Turks, and Jews and Armenians. It has been trying to be named since Galen, with cyclic fevers attributed to different moon phases, for example, after 2nd century AD, and Heberden, and Osler, and Siegel, and Katan and Mamo in 1951 noticed the association of FMF with renal disease after Siegel described it benign paroxysmal peritonitis. In fact, it's an inflammation of serosal, not only peritonitis. I'll briefly overview it later. And in 1997, two separate groups succeeded to diagnose the FMF as a monogenic disease, which is located in the short arm of 16 chromosome. And originally, it is known that it has an autosomal recessive pattern, but I told you before, and under the clinical suspicion of recurrent fevers with mainly peritonitis, here are the criteria: recurrent fevers, abdominal pain, chest pain, arthritis, and a family history of FMF. We can diagnose, we can drew blood for genetic MEF-V analysis and diagnose FMF with a high sensitivity and specificity. Let's turn back to several involvements of the organs and systems in the body. Mainly, we have peritonitis, sterile peritonitis, but pleurisy as well, and even headaches and pericarditis. These are recurrent but not periodic. It might be recur every week or every 2 to 3 months. And the main problem is amyloidosis, mainly affecting the kidneys. And we can see some vasculitis in FMF more frequent, such as polyarteritis nodosa and the IgA vasculitis, namely Henoch-Schönlein purpura. And especially males with arthritis and arthralgia are at risk of amyloidosis. Let's briefly look at the risk groups. Patients with homozygous or M694V and serum amyloid A homogeneous inheritance, male sex, family history of amyloidosis, and arthritis attacks are risk groups for amyloidosis. And I told you about the criteria. First, the Jewish people, scientists, had Tel-Hashomer criteria we still use, but we have our criteria in other terms, Ankara criteria. As I told you, 3 or more attacks of fever over 38 degrees Celsius, abdominal pain, chest pain, and arthritis. 2 or more parameters of these have a clue for making the diagnosis of FMF, and we send patients for MEFB analysis. And let's go back to inflammation in terms of pathogenesis. Inflammation is a physiological response to endogenous or exogenous pathogens, as you know. Innate immunity, neutrophils, macrophages, and natural killer cells mainly play a role. And there are PRRs, pattern recognizing receptors. There are phagocytes in innate immunity are activated via PRRs. They are located in cell surface, as well as endolysosomal compartments and cytoplasm and nucleus. Their activation leads to activation of intercellular signals and production of pro-inflammatory cytokines and interferon. And let's see how these are related to FMF. In PRRs recognition, there are some pathogens. First, PAMPs, pathogen-associated molecular patterns, and DAMPs. These are mainly, the first are mainly with external pathogens like some microbes, microorganisms, and then the other endogenous molecules of apoptotic cells and homeostasis-altering molecular processes such as cellular homeostasis changes, for instance, infections. And here we can see in the scheme that you can see the extracellular receptors. For example, here toll-like receptors and intracytoplasmic receptors, node-like receptors, and finally, as Karim told about immune deficiencies, NF-kappa B in the nucleus. Here we have an aberration of these systems. Here we can see on the right the pyrin forming an inflammasome with ASC protein combination. Finally, through pyroptosis with Gazdarmin pores leading to inflammation, and with the release of mainly interleukin-1 beta and 18. From the view of inflammasome patterns, there are 5 main inflammasome, which NLRP3 is mainly examined, and we have much knowledge about it. And here is pyrin, which stimulation signal is from ROA GTPase inactivation, as for example, Bordetella pertussis and some other Clostridium species as well. And downstream signal is through PKN1 and 2 inactivation and reduced pyrin 14-3-3 interaction, and mainly leading to most seen disease of our country and Mediterranean with FMF, and some other, for example, pyrin-associated autoinflammation, PAANT, and mevalonate kinase deficiency, and PAPA syndrome as well. Pyrin MEF-V is a human gene that provides instructions for making a protein called pyrin. It is expressed from granulocytes, monocytes, and fibroblasts. And pyrin dephosphorylation is mandatory for inflammasome activation. Inactive pyrin is bound to, here you can see 1433 protein is inactive pyrin by inactivation of RhoA GTPase, for example, by bacterial toxin, leads to inactivation of here PKN1 and 2 kinases, and thus pyrin dephosphorylation occurs here on the right side, and loss of 1433 inhibition and causes pyrin activation, which interacts and forms pyrin inflammasome, leading to inflammation through activation of caspase from inactive phase and leading to hypersecretion of interleukin-1 beta and 18. Here we can see clearly the ways cell is affected by PAMPs or DAMPs. There are many important 5 inflammasomes, which one of them is pyrin here. And with ASC protein, it is activated and turns procaspase into caspase through pyrin inflammasome. And then with gasdermin, it forms a cyclic pattern and creates pores in the cell membrane. And through pyropitosis, especially, interleukin-1 beta and 18 is released and targets many organs, leading to recurrent fever, serositis, arthritis, and mainly these features. Let's go back to early century. There are cities with repeated plague outbreaks from 14th to 18th century. You can see the outbreaks in colors, in different colors. And Yersinia pestis has killed millions of people, mainly in Europe and Anatolia, but ancient mutations, we speculated before, ancient mutations with FMF have not suffered from these pandemics. Then finally in 2017, Chinese scientists proved that ancient familial Mediterranean fever mutations mainly M694V and V726A had resistance to Yersinia pestis. Let's try to explain this. Yersinia pestis pathogenic virulence factor is YOP-M. Normally, YOP-M blocks normal pyrin biophosphorylation and inhibits interleukin-1. But mutant pyrin is not affected by YOP-M. Thus, when millions of people dies from the plague epidemic, the people with FMF mutations have enough interleukin-1 increase, and they are not suffered from the disease. And throughout the years, this is an advantage. This has been an advantage. And from generation to generation, we still have these mutations with other 400 mutations as well, but especially exon 10 mutations are important. Briefly, treatment is we want to control the attacks, mainly fever, serositis, and arthritis. Colchicine is the standard therapeutic drug. And in case of colchicine unresponsiveness or resistance, whichever is you can choose, interleukin-1 inhibitors play a role, as we talked about the pathogenesis in the pathogenic diagrams. Colchicine is firstly used for good gout arthritis. Colchicum autumnale, it's a plant, and it has even known 1500 BC by Ebers Pyrrhus, and in 1972 it is used in FMF, and it has FDA approval as well. Its anti-inflammatory effect is in many ways. First, preventing neutrophils to attack the site, preventing NLRP3 inflammasome and caspase-1 activation as well, and preventing the neutrophils adhesion to the site and trying to prevent the attacks. And specifically on macrophages, it blocks ROE inactivation by cytoskeleton rearrangement, and of course caspase activation and inhibition of secretion of interleukins, specifically pro-interleukin 1 through interleukin 1 beta. In the treatment, first, we have the traditional ancient drug colchicine, very, very effective. We can control in 95% or 90 to 95% of patients with colchicine. But in the others, we need, in case of resistance, we mainly use etanercept, not etanercept as a TNF inhibitor, but interleukin 1 inhibitors. Interleukin 1 alpha and beta inhibitor, anakinra, interleukin 1 beta inhibitors, canakinumab, and rilonacept, which rilonacept we don't have here in, I think it's mainly in the States. And these drugs, as I told you before, inhibit the NLRP inflammasome and inhibit the active interleukin 1 beta release. And finally, we had a hypothesis. Can we diagnose FMF by other ways? Because we have some problems in diagnosis. For example, when we have a child with recurrent fevers, we first try to eliminate the immune deficiencies, of course, immune dysregulations. And when we think of an immune aberration mainly FMF, we need to have genetic analysis. But as I told you before, even in the carrier state, if there are signs and symptoms for FMF, we try colchicine and make the diagnosis by a positive response to colchicine. But we wondered if we could measure pyrin levels. Is it possible to measure pyrin by using a biosensor? Because we know there are some other diseases such as PAPA and PAANT, which pyrin levels and mevalonate kinase deficiency, with pyrin levels increase. But mainly we have the disease FMF, and we could make an algorithm if we can measure the pyrin levels, and I'll show you later. First, we found an economic and portable biosensor for pyrin detection for diagnosis of FMF with Izmir Biotechnology and Genome Institute collaboration. What is biosensor? It's an analytical device that converts a biological response to a measurable analytical signal. It depends on which one we may want to measure. For example, heavy metal, chemical, toxical, here pyrin protein, and then biosensing of the analyte by immobilized whole cells, here immunoglobulin G, IgG, and then turning it to electrochemical or optical or piezo or respiratometric signals, here optical signals, and finally digital amplification and display of signals. And its detection takes place in 3 steps: binding of the analyte to a specific recognition element, that is bioreceptor, here pyrin protein, translation of biologic binding event into a signal, here I told you optical, and processing of the signal into useful information by signal amplification. So what we did, we found, we took a golden nanoparticle and we placed IgGs directly on it. And then when we used the media from children with homozygous mutations of FMF, homozygous exon 10 mutation of FMF, we found that if there is pyrin in the media, IgG molecules could bind to pyrin and reflect the level of pyrin. How? Here we had healthy children and known homozygous exon 10 mutations children here, FMF, let's say FMF negative, FMF positive. And when we used the biosensor, we clearly could measure a spectral integral significantly different from healthy peers in patients with positive FMF positive patients. And when we use the graphical user interface, and when we interact through the signals to user interface like this, we showed that we could show that the patient had FMF. So we could do it in a very short time, namely in the same day after we take blood and some processes. I couldn't tell you in detail here because of the time. And in half an hour, we can see that the patient might have FMF. As I told you, there is an algorithm for FMF, which is a paper by Özen in 2013. A child with unexplained fever with high CRP levels and meeting diagnostic criteria, and excluding immune dysregulation, of course, and we ask any skin rash other than erysipelas-like erythema, because we can see recurrent arthritis of FMF with erysipelas-like erythema. But if the patient shouldn't have oral ulcers, psoriasis, panniculitis, or features of PFAPA with exudative pharyngitis during attacks. If we say no to it all, we take blood for main MEF mutations, especially including exon 10 mutations, as you see here. It takes 3 months and it's expensive. Instead, if we can apply this here, our device, a biosensor, it takes half an hour and it's economic. I think we'll be able to be waiting for the patent from TÜBİTAK, and I hope in the next year we'll be able to work on the patients with heterozygotes as well and other types of FMF. Thank you for listening, and I would send my love with my pediatric rheumatology family from Izmir and Turkey.
Thank you very much for your excellent talk, Erbil. Now I'm looking at chat box. Yusuf is online, okay. Any question, please write in our chat box. Okay, there are some congrats, thanks, I see right now. So let me ask you a question as a privilege of moderating this session. Yusuf, is there a specific relationship between immune deficient disorders and the source of infections? I mean the agents.
Well, in the sense that you can predict to some extent what sort of immune deficiency the patient has by the nature of the infection. So, for example, if you have patients who have infections with Staphylococcus, you're looking more towards a phagocyte disorder such as chronic granulomatous disease, for example. So fungal infections and staphylococcal infections, abscesses would be more towards CGD. If you have encapsulated bacteria, Streptococcus pneumoniae, affecting, say, respiratory infections or otitis media, Haemophilus influenzae, these sort of bacteria, these are more suggestive of a primary antibody deficiency. And then in young children who have a severe combined immune deficiency, unfortunately, they're vulnerable to everything. So severe viruses such as CMV, fungal, pneumocystis, as well as bacteria, because obviously in those cases, both T cells and B cells and therefore antibodies are affected. So yes, often it's something that we really do look at when we're deciding what sort of tests to do. So if a patient comes in with recurrent abscesses, we will be more prone to do lymphocytic tests and neutrophil numbers, neutrophil function, rather than looking down the antibody route. So yes, that in part of the evaluation and the history, the type of infection is important in guiding us to the pathway for investigation and diagnosis.
Thank you very much. I will, actually, we are at the era of COVID-19. And I remember some news about the colchicine treatment in FMF. Maybe there's a contradictions or conflicts. So do you have any comment on this?
Well, during pandemic, we were very nervous, of course, about which drugs would be available, which drugs could prevent us. And if we had some problems with our pediatric rheumatology patients, including FMS, but it's good that we didn't have any problems with our rheumatology patients, and except steroids, we continued using colchicine and even biologics during pandemic with tight control of the patient, of course. And regarding FMF colchicine, there are some studies maybe still going on, but I can't follow because of the pandemic is almost over, and the importance is mainly on anti-interleukin 1 and anti-interleukin 6 treatments. There are some papers about colchicine treatment and is it protective, but there are not certain evidence about the protectivity or treatment of this plant, let's say.
Thank you. I'm looking at the chat box. I'm seeing positive feedbacks and also thanks for both of you. And I would like to also once more thank you for your participations. And I would like to thank to Professor Funda Erdoğan for organizing this event, series of events, and also Nur Olgun, our dean, for their help. Everything. Just a question in the chat box, maybe the last one. Professor Zeki Altun is asking about E14-8V mutation in FMF. What about the clinical progress? I mean, the relation.
Okay. Thanks to Professor Altun for her question. There are many, after the founding of MFV gene in 1997, there are many genotype-phenotype correlations. And we have now in Fevers database, we have nearly 400 mutations. And we were very anxious to find a genotype correlation, but now we know that in specific parts of the world, for example, in Anatolia, exon 10 mutations are prevalent, and mainly M694V mutation is important. Regarding E148Q mutation, it has no meaning for us in terms of making a diagnosis. But in Armenians and Persian, Iran, it is important as a pathogenic mutation. But in Turkey, we cannot, we don't include in our diagnosis portrait. In other terms, if a patient has, if a child has recurrent attacks, fever, peritonitis, or arthritis attacks, and has only this mutation, we are trying to look for another periodic fever.
Thank you. And Dr. Ceyhun Acharya is asking a question about the advantage of the new method in FMF diagnosis over the classical method.
Thank you. Ceyhun is one of our colleagues who worked with me with this project. Actually, he asked the question with his dear wife from the Izmir Biogenome Institute. Thanks to him. And the advantage is, as I told you in the presentation, it is cheap, it will be cheap, and it will last only a day and half an hour after we processed one drop of sample over the golden nanochip, and we will be able to see the level of pyrin. Yes, is it FMF? We need to talk, and we need to make we need to try homozygous as well and heterozygous patterns, and we need to exclude other few diseases in which pyrin there increases. But as Anatolia, as I told you before, in the Mediterranean, this project, this biosensor, will help us much for the diagnosed FMF in a short time. Thank you.
I would like to thank you both, Yusuf and Erbil, for your excellent talks, and we hope to see our colleagues both in Sidra and 9 Eylül University. Next one, we are going to have 2 lectures in 1 month, and hope everything will be okay and fine. And I will say goodbye. Greetings from Izmir. Bye-bye.
Thank you so much. Thank you so much.
Bye-bye, Arsenal.
Thank you. Galatasaray.
Thank you.